Hello, how are you doing, Kirat? Nice having you here. And well, we want to learn more about yourself, what you're doing within the healthcare space. How are you helping others change, evolve, and become better and healthier? So I'll pause here to pass the microphone over to you and learn more about you.
Thanks, Lilia, for having me. My name's Kirat Kharode. I'm the CEO of Heelco and founder. We're building a market network for employers and providers to be able to provide healthcare through a health plan, a community-owned health plan. We provide direct care through contracting between primary care doctors and GYN and specialists and employers directly. And through a new community-owned health plan model that we're offering, we aim to save employers 20 to 30% on their premium costs and share savings on unspent premiums from their claims fund on the back end every year. And so our goal is to deliver cost care as conveniently and as quickly as possible with the highest quality but lowest cost for the self-funded employer population.
Perfect. Thank you for elaborating on it and providing us with some details and the background around Heelco. So, just to learn more how it works, if there's anyone that has employers or well, employees in this case, how can they learn, like jump into the program or just to see how it works?
Yeah, they can reach out to us via LinkedIn or at hello@heelco.us.
Perfect.
We're working with groups of 25 lives and larger. Generally, our sweet spot is around 250 to 500 lives. And so we do a claims analysis. It usually takes us about 10 days to look at the census data that the employers are populating and turn around a proposal based on where their employees live on what we can do to reduce their overall inpatient claims, look at any kind of laser claims or other bigger, larger claims that they've had over the last couple of years, and then create a program around that that really can deliver care as high quality as possible to their population where they live.
Perfect. And as I understand, they can build their bundles, right, according to their needs. That's how it works.
Correct. That's
Okay.
right.
Okay, perfect. So the main idea is to assess what are the main needs based on where they live and what they are trying to support their employees with. And that's how they can have a bundle in place that will support their immediate needs, correct?
Yeah, the bundles are one cost saving tool that we use because they allow us to deliver almost like a subscription type model
Okay.
in a predictable cost to the employer, and the employee knows that they have for example, with direct primary care, they can access their doctor by text, by uh, calling them or visits, whatever they need. And we've done similar maternity bundles for 10 months where we've negotiated the entire prenatal, the hospital visit, all of that. So it's a predictable cost rather than an unpredictable thing. So it's much more from if you know that there are certain areas where your population is more likely to, maybe have have members that might have a baby, or if you have a history of certain types of musculoskeletal or other things, those are sort of the bundle type opportunities that exist because they tend to be the higher cost claimant issues, especially when a mother or a baby goes to the NICU. So that really can spiral out of control. So we try to focus on the high cost areas to create bundles, but beyond that, we generally use Medicare reference-based pricing so that the cost has a cap on it and that the hospitals can get paid fairly and on time without having to go through prior authorizations and those sorts of things.
Thank you. Thanks for expanding on it and obviously clarifying a couple assumptions I had there. So that's great. The other thing that comes to mind, or I was wondering while looking at your website and after we spoke, one of the key things that I'd like to better understand is this, or it works as a platform and then there's data that others can review, and there was as well something specific to cafeteria plans as well.
Yeah, so there are all different types of things where there are tax incentives that can be created, that can be tax advantaged accounts, like health reimbursement accounts. And employers have a lot of different flexibilities that they can use in order to deliver this healthcare to their employees. So if they want to do indemnity plans, which involve more of the health reimbursement account, or if they want are self-funded in terms of their financial chassis. It really doesn't matter to us. We really our goal is to always deliver the lowest cost and highest quality healthcare within that plan as possible. So all the different instruments that you're describing are all different financial chassis that can be possible for them to fund their healthcare. Some employers who are smaller go through the fully insured route and go in the United States go through the ACA exchange and the marketplace for that. The groups that are large enough, and for our case, that's 25 lives and above, can pool their risk in various forms, including captives, consortiums, associations, or this level funding mechanism that we offer, or self-funding through our community-owned health plan model, where on the back end, any unspent premium dollars will be returned to the employers, which is very different than the big carrier plans, which don't do that. And then they've been for years they've been increasing the premiums and just profiting off those things. So that's really where the American health system has really been on a death spiral, because premiums have increased for employees and families by 56% over the last decade. And it's now on employers' line items, second to payroll, the highest costs that they have is providing health care to their employees. And so for employers, they have a lot of different choices, but when they choose to not do anything, or when they have to go through the fully insured market, or if they choose to do something like an individual coverage health reimbursement account, they are able to go to the exchange and get pooled their risk with the many people through plans that are offered by Blue Cross, United, Cigna, Aetna, and Humana. However, the premium costs are so high that often even by offering those plans, their employees become functionally uninsured, because they really can't afford to pay the balance of whatever the premium costs in the marketplace is. And plus the access to getting into doctors using plans like those are often 26 to 45 days out. With our model, with direct contracting, doctors get paid transparently. They get paid on time as soon as the visits happen, and therefore they're more likely to allow our patients to be seen right away, kind of fast track our patients in, because they don't need to wait for authorizations and those other types of things that often the big carriers require.
Perfect. Thank you. Seems like you have solved lots of headaches and obviously providing more of an affordable healthcare. So that's a great solution in place. And one other question that I have regarding the coverage, or where Heelco, sorry, is covering. Is it full US territory? Okay.
Yes, we have a national PPO that we're working with, and that's a preferred provider organization. So, in any market across the country in the United States, we can roll out a community-owned health plan, partnering with employers. Again, it's just about the size of the employer lives. We can't go below a certain size, because we do need an adequate risk pool. But 25 and above, anywhere across the country, we're working with associations, we're working with employers, and right now is renewal season, and so there's a lot of activity around people wanting to get new plans by 1/1. So half of the companies generally get renewed on by January 1st for a January 1st kickoff, and then the rest of the country kind of trickles in throughout the year.
Perfect. Thank you. And the other question I had just with what you were mentioning just disappeared, but well, obviously the way it works for virtual type of care is applicable.
Yes, so we do $0 out of pocket for any direct care that's access to our network, and that includes virtual.
Okay.
But it also, with the ability to access your doctor whenever you need, where the real impact of anything like telemedicine or being able to text your doctor or your care team, we have a AI navigator, which we call Maistro, that we've been building, and it's a voice agentic layer that's really focused on speech to intent to allow members when they call in to be navigated to the lowest cost setting as possible. And so we've been building this to really be focused on getting patients to the right place at the right time in the right care setting with the right provider as we can. So they can really do that asynchronously. They can do it virtually. They can request near site appointments, and we do share offices across the country with thousands of providers who have existing practices. And then when we have a direct care doctor, our doctors float into those offices as needed. But we also do on-site clinics with employers as well. So if they choose as a part of their plan that they want to have an on-site doctor, we've also enabled that as well. So direct care doctors can go to their work sites once a month or twice a month, whatever the plan allows for, and they can deliver that service.
Perfect. That sounds great. So, talking about it, probably this is one of the perks, as you mentioned, going to the office and providing the care that helps a lot and speaks highly about these companies that are like doing the best they can and providing the right care for their employees. And talking about the AI, the agentic uh, solution you're working on, how is that obviously changing the vision overall, the journey, and do you see that it's going to be a game changer too?
Absolutely. I mean, I would say that within the last 12 months, definitely over the last 2 years, the acceleration of AI and really the agentic movement has already started to impact the way that care delivery can be optimized. But also, in so many different layers across the industry in ways that that the whole industry, whether it be around uh, payment integrity or potentially identifying higher cost claimants before they reach a point of the emergency room or really a high cost episode. So our goal and the way that we see it is that it's not replacing the physicians, but really that first care navigation layer to help us identify when people are in distress, putting them in and with resources that they need, so that ultimately we can curb the high cost episodes, downstream. And that doesn't always show. I mean, the difficulty about what we do from showing a cost savings is that obviously when you nip something in the bud and have preventive healthcare, you're not going to have the high cost emergency room visits. Maybe the cardiac episodes, maybe some of those things are going to be avoided. And it is a very much a long-term game that we're playing. And so while AI is giving us an immediate opportunity, and we see that, with navigation, all the things that we can do to help move patients to the right setting that they need to be seen. There's just so much more that's coming down the pipeline with how we can incorporate these technologies to better serve our patient population and our providers.
Totally. I find the trend and the way AI is being used within the healthcare space is that specific manner, which is you have this tool is available. I find there's so many options we can make use of it, but it's totally just to support, to provide bandwidth, and obviously for healthcare providers to have that s- mm, time to be able to help others, more patients, rather than going more into that work that it's not really what it's valuable and not helping others. So totally in line with that, we have to make the best use out of it, to use it wisely, and obviously it's going to make a huge change on how the probably saturation we've been facing on the healthcare space, others too, but in specifically on the topic we're discussing, I think it's a game changer. So kudos on that.
Thank you. Yeah, I agree with you completely.
And other questions that I had overall regarding how Heelco works, specifically for providers, is it type of a way like they join, they're part of a network, and Heelco is like makes them available? Is there something specific on that topic?
Yeah, so what we've experienced as an industry over the last 10 years has been a massive amount of burnout of clinicians. Uh, Over the last couple of years, the numbers are staggering. Over $100,000 doctors have left the profession completely. There's a lot of factors around that. A lot of that involves the way that the traditional fee-for-service billing environment works. And I spent a lot of years in hospitals actually recruiting doctors and putting them into models like this. So I'm kind of undoing a lot of the things that I've done previously in terms of the right way to deliver care, which is transparent pricing, one that the doctors aren't constantly having to bill and justify their clinical decisions, against a middleman carrier. And that's usually what happens with the big Blue Cross United, the BUCAs as we call them. And so for providers, our mission has always been to empower the independent doctors, whether that be providing infrastructure so that they can grow their practice, share offices, have an agentic agent that's answering calls for them and helping them create these bundles, which allow them to offer their own storefront in many ways with their own unique product without having to opt out of being a part of Medicare. And so what we've done is created our own clinical practice of medicine. We have our own physician ownership of that group that allows us to recruit doctors, allows them to practice within the confines of our practice and deliver direct care without jeopardizing their Medicare contracts, without jeopardizing their fee-for-service contracts that they have with commercial carriers. Because when they're working with us, they're exclusively providing direct care contracts and bundles. They're not billing insurance at all. And so it is a unique opportunity for doctors to explore how they can migrate away from the fee for service world and deliver care directly to patients and employers.
That's great. It's a great achievement that you'll find through time. I think it's going to make a difference because the overall end goal, I guess, you have is supporting affordable care, and it's going to expand and reach more people around the US.
We have no
And
choice.
exactly, yeah, it has to be addressed. And obviously, as you mentioned, like there's maybe this, I don't know if I can say levels or stepped approach. From what I saw is cutting down the costs, providing best in class care, and obviously through the AI support, then it's going to help as well throughout the patient's journey and care. So it makes total sense on the way it is coming together and how you are uh, putting out the word out there.
Thank you. Yeah, we just have to be able to. We don't have the model in Canada yet, but you guys have a slightly different system than we do.
Different, but well, there's as well lots of things and ideas that I find will be amazing to implement over here. So
Sure,
it's good to learn how each country and healthcare system has its own challenges,
sure.
and good
And
to
things we can
see.
learn from. Hopefully,
Yeah,
there's best practices in other countries that certainly we can build on, and so that's great.
Yes, totally. I'm just probably circling back on the your previous experience or your professional career. I find that's a great way to know, like, you have this experience within the field, and now you're putting some of those solutions in place that will help alleviate some of that pain points, burden overall for providers as well. So I find this is a great way to expand to provide this support. And as you say, they are still able to keep Medicare, which is something that is quite utilized within the healthcare system.
Yeah, it's important that the doctors don't feel like there's that it's a binary choice that they have to make, and that either they are, go completely concierge or direct care, and that they only can accept patients that are, cash paying or have a health savings account and some membership, versus, sometimes there's doctors who do inpatient work, right? And they can't opt out of by opting out of these contracts with BUCA and the federal government with Medicare and Medicaid, they wouldn't be able to practice as inpatient hospitalists or laborists and work shift work in the hospitals. And a lot of them want to maintain their clinical acuity and use that as a additional source of income. And so, I think it's really important that doctors have a choice on and allow them to have the off ramp into direct care when they have enough of a patient population that necessitates it. And so we're the bridge that creates that by having the employers directly contract through our vehicle and through our infrastructure. We're able to bring that part of the network with the doctors that are independent and create that alignment that otherwise would be, going through the big carriers and relying on them to adjudicate claims, and then ultimately lining the pocketbooks of the big carriers rather than returning unspent premium dollars to the employers, like the Heelco Health Community Health Plan allows for.
Thank you. That's great. So I find we have covered lots of topics, and obviously these any type of regulatory and compliance challenges are well taken care of. I think there must be lots of thorough planning and investigation. So that's something that I just want to make sure that's how it works. And given you have all the like this background throughout your career, leadership, mindset, and this framework or lens of working within the healthcare space and having other types of skill sets that you've built through time has come together as an overall solution.
Yeah, I spent my career as a hospital system executive, and as I mentioned, I spent a lot of time, in essence, the highest costs of the entire system come when you get hospitalized. And I thought I was doing the best. I was doing the best that I could, and achieved a good amount of success. But when I look at it from in retrospect, what I was doing was really just adding to the overall cost of care, and that and just feeding into the machine. And so as hospitals now are being compelled to look at more value-based arrangements, and the cost infrastructure needs to be shifted, and that cost curve needs to be bet down. There's more and more opportunities for us to create ways where the hospitals can be paid fairly, but really not cost the employers, the federal government, and the unions, who are essentially the payers of all healthcare, to be put out of business by just egregiously rising healthcare costs, both on the major medical side, but also on the specialty pharmacy side. So it has been a complete change for me, because obviously, having run hospitals for a very long time, and recruiting doctors into the fee for service world, there is a lot of things that we have to do, that will be undoing what we were doing before. But there's room for everyone. I mean, there's 150 million plus self-insured employees in the United States, and that's roughly half of all the insured population. And so, yeah, there's a lot of room to grow, and we have a lot of opportunity here deliver good care in the future.
Thank you. Thanks, Kirat. I am sure and certain about it. So before we wrap it up, we're sharing below the links to your social handles, to your LinkedIn profile, so they can follow you and see how things are evolving, how you're changing uh, the healthcare space and the care provided. And just to know if there's any final thoughts, comments, or something that you want to spread the word on with the audience. I find this is a great venue for any maybe insights you have, any advice that will be valuable for them to keep.
Yeah, I think that I think there's a natural tendency for business owners and those who have to deal with healthcare insurance as being skeptical and nervous, and rightfully so, given the enormous costs that it has on the employees as well as the employer's balance sheet. I would just say that you the as of in the United States as of 2021, the government there's a Consolidated Appropriations Act of 2021, which made employers the fiduciary as the plan sponsor. They're the fiduciary for their plan, and they have to make sure that they're doing everything to ensure that they're delivering the best, highest quality health plan for their employees as possible. And so, if they're finding that there's a broker who constantly just says, it's not worth the disruption to take out the big carrier. If they're constantly kind of not evaluating other options that might exist, then I think they should need to question their broker or advisor to consider other alternative health plans like Heelco's community-owned health plan to save their employees money ultimately, because ultimately it's the employees that are losing wages by not, but in a different form by paying more and more for healthcare over the last 10 years. And so that's something that's going to have to change, and we're trying to be a part of the solution.
And I bet also, or I can say, there's no harm on just going to the website, looking into it, and then requesting a quote. Obviously, that's the right step to take and figure out if that's a solution or what is the implications to it. But totally makes sense of sometimes going out of the regular things that everyone just goes to, as you say, like the big insurers, and that's it. That's the
Mhm.
way to go, and that's how we've done things. But making um, informing taking an informed decision, I think that's going to be a game changer too.
They say that nobody ever got fired for hiring IBM until they were fired for hiring IBM, right? So so there's a reckoning coming for the big carriers, and I don't think that and it's no longer just us against the machine. There's a tribe of many people across the industry who are trying to impact this in a really meaningful way. And we just have to look at this in a pragmatic manner, because since COVID, there was, people weren't using healthcare during COVID. There has been a big pickup since then. Now the medical claims loss ratios of all the insurers are tipping over to a point where they're paying a lot more of the premium dollars to actually pay for claims, because gene and cell therapy and those types of things are emerging as really high cost as high cost claims. NICU claims are rising. I heard I was at a self-insured conference for self-insured employers and brokers and TPAs and reinsurers. And there was one participant who was talking about a $9 million NICU claim that they just got hit. Now, if you get one single $9 million NICU claim, it's going to destroy your overall claims budget for the entire company, and it's going to impact your premiums for the next year, and so forth and so on. And so there has to be things that need to be put in place to look at the cost of care and make it more predictable for the employers in the future. And that's I think where we're headed: cash pay, transparency, access, and quality.
Perfect. So thank you. Thanks for sharing that. Like data also helps as well to share across what can happen, like how it can come into play with numbers, financials, and whatnot. So that's great to know you have specific data and how it can uh, create some burden overall. Okay, Kirat, it was a pleasure speaking to you today. Happy to talk to you, and well, take care. Thanks.
Thank you so much.
Bye.